advertising because they said, oh yeah, you can do this posterior fusion only, and then 4 out of the 6 patients actually had failed posterior only fusion. So anyway, this is just some examples of that. And this is a more severe deformity. This is one of my kids who had this progressive deformity, was getting up to 65, 70 degrees of kyphosis, and I said, okay, enough's enough. And so it's hard to see here, but you can see a little bone graft in the front there, and then fusion in the back with a very nice result, and this child's done well since, and I think he's probably about 7 or 8 years post-op now. Scoliosis is not so common in MPS. I've only really seen it in Morchio, to be honest. But you can have a little bit of scoliosis associated with kyphosis, but really kyphosis is the primary deformity. The difference between kyphosis and scoliosis is that kyphosis tends to encroach on the spinal cord or the neural elements, and so it's a neurologic problem. Scoliosis tends to not have any real neurologic problems, but it can compress the chest cavity and result in pulmonary compromise. So there's different reasons to be concerned about these two different deformities. While they both involve the spine, they have different sort of long-term implications. And so this is a child with MPS 1 who, as I just said, I don't really see it, but this child had scoliosis and was being observed at this point. Early onset deformity is common, and meaning that under age 10. But again, they're often kyphotic, and it's usually associated with kyphosis. And the kyphosis is probably in this child who I don't show the side X-ray here, but also had a kyphosis associated with that, which was probably the driving factor here. And again, they're progressive and result in cardiopulmonary compromise. And then as far as treatment, now scoliosis is much more easily braced, and so we brace often for scoliosis, especially in younger children, because it does slow the progression of the deformity. And again, we're trying to wait as long as we can before we intervene with spinal surgery. So we don't really know. There's a cutoff point where when do we do growing rods, as shown in this lower film, versus a definitive fusion, which is shown in the upper X-ray. And most people say somewhere between age 9 and 11, you should start considering definitive fusion. It really comes down to how much growth you have left. How much growth do we need to promote to allow lung development, and really what are the child's demands. So a child, say, who is in a wheelchair is not going to have the same respiratory demands as a child who's out playing sports. And we have MPS children who are both. Right? They can be anywhere on that spectrum. So, and the key is really individualizing that decision making. And so here's a child who, you can see the scoliosis. This is an MPS 4 patient, and then you can see the associated kyphosis, which is driving it there. And then, this is a definitive fusion. This child he wasn't really a child, he was a teenager. He was probably 14 or 15 when he had surgery. And so this is what the kind of outcome. This is a more modern type approach to this. Moving down to the hips. So we talk about epiphyseal dysplasia, and then we talk about subluxation and dislocation. So these are two different issues. One's a biological issue and one is a mechanical issue. All right. Now this is not an X-ray of a child with MPS. This is a form of multiple epiphyseal dysplasia, but it looks very similar. And oftentimes, diagnostically, these two conditions get confused when you're trying to make a diagnosis. Oh, I didn't do that. Anyway, so epiphyseal dysplasia looks like osteonecrosis, and that's why many MPS kids are diagnosed with quote-unquote Perthes disease before it finds out that they have MPS, because Perthes disease is what we call idiopathic osteonecrosis of the hips. If you have MPS, it's no longer idiopathic. Idiopathic means you don't know what's causing it, and if they have MPS, we know it's MPS causing it, okay? So they don't have Perthes disease, they have MPS. So I'm going to talk a little bit about both these things. So this is, again, another child with multiple epiphyseal dysplasia, but again, when I talk about epiphyseal dysplasia, I always put MPS at the top of my slide because it's something that you can test for, it's something you can treat. And so when these children walk into an orthopedic surgeon's office, they need, and so right now my goal in life is to tell every orthopedic surgeon how to identify and test and diagnose patients with MPS. Somehow this got put on some automatic advancement. Sorry. So this is just more on epiphyseal dysplasia, but epiphyseal dysplasia basically results in joint pain and precocious arthritis, and that's why patients with MPS end up needing joint replacements. So, and anyway, this is a little bit more on that. We can kind of skip over this. So this is Hurler syndrome. So I put on the left side for you a normal, quote unquote, normal hip x-ray, all right? So you see nice round hips. You see the ball is in the socket's round, it fits. And then you see this MPS 1 patient. This is a 3-year-old with Hurler syndrome who had a stem cell transplant. So stem cell transplants don't prevent hip disease, okay? It doesn't matter the source. But I'll show you kind of in a more detail here on the next slide what we're looking at. So what we see is what we call a break in Shenton's line. So this is a sign of subluxation. If you see this means the hips probably need to be operated on at some point, okay? And why do we have this break in Shenton's line? Well, you have sort of a different shape to the proximal femurs, what we call coxa valga. Again, it's pointing away from the midline. And then you have what we call acetabular dysplasia, which is represented by the increased acetabular slope, or what we call the sourcil, which is French for eyebrow. And this results in what we call in lateralization of the femur out of the hip joint. And so this is hip subluxation, all right? So we know that these hips untreated get worse. So this is a scenario for the most part, especially in MPS 1. I don't know how to, there's an automatic advancement here, right? So these get worse, and this is a study that I helped participate in out of the Netherlands, which shows that, you know, untreated, these hips get worse. You can kind of see this dotted line. This is normal hip development, and then for the most part, the MPS 1 hips get worse. And we've seen this similarly in Morchio, where the hips this line should go the opposite direction. It should go down, not up, and so so we see that these get worse, and usually this is a grade of arthritis, tonus grading of arthritis. You can see by, you know, they start out not so bad, and as over age 13, almost all of them are what we call tonus 3 hips. So and none of them are grade 1. So based on this information, we've tried to make some recommendations as to when you should operate, who should get an operation. So if you have progression on X-ray, presence of pain or disability, or expected progression of symptoms, and that's where it gets a little bit tricky, that's when someone should have a surgery. And this is really driving me crazy, I'm sorry. Early corrective surgery should be considered in these kids. So what do? We do what's called a pelvic osteotomy and a femoral osteotomy. Osteotomy just means cutting the bone. So we're just cutting the bone and reshaping it. And there's different ways you can do this. And so you can, if you go to DuPont, they're going to do what's called a shelf acetabuloplasty. And in my hands, I'll do what's called a Dega innomina osteotomy. The result is that you have a stabilized hip joint, and that's all that really matters. And this is some x-rays from Will McKenzie where he shows this shelf, and you can see this bone overlying the hip, and here he hasn't done his femoral osteotomies yet, or maybe they've already been done, but these are, I'm sorry, this is a little bit longer term outcome. And this is the way I do it, which you can see it's similar. You're cutting the bones, you're realigning the femurs, and you're reshaping the acetabulum. So San Diego Dega osteotomy is the same thing. So. And this is just an example of one of my Morchio patients who you can see these, again, you see this subluxation of the hips, and my automatic thing is going, so we'll just go with it. And this is the surgery, and this is right after surgery, and a couple years later. Now you can see here the epiphyseal dysplasia is actually continuing to go despite the fact that the hips are well seated. And then this is an MRI of that showing that there's cartilage there and the hips are really in joint. But there's 9 years later, this is hips are in the joint, but this child is going to need a hip replacement at some point. So I think, you know, we think and hope that we have postponed that need to a later age, and so, but we don't really know. So this is some data out of Minnesota, where they found that really the surgical patients long-term, or this is medium-term outcomes, I think it's somewhere in the order of 5 to 10 years out. Some still developed arthritis despite having treatment, and there really was no difference between those that were treated and those that weren't. We're not. We think we're helping. Maybe we're delaying. It's hard to say. And then this is some information out of DuPont, where again they had good outcomes. They tried to do a different kind of osteotomy. They probably didn't have enough coverage of the hip, and so that's why they went to this shelf acetabuoplasty, because it's a very robust procedure. And the point here was that they all did, their Morchio patients did very well, but they had to sort of finesse their technique to make it go. And then this is some long-term data out of Ireland, and I think the columns that I have highlighted here to show you that if you look at degenerative changes in the hip, 10 to 15 years out, there's some that have none, and there's some that have advanced arthritis. And so these are all kids who had surgery. They had a lot of them, they didn't do the same surgery for all the kids, so it's a little bit of a mixed bag, but the point of the matter is we still don't know long-term whether we're doing the right thing when we do hip surgery. So it's not so simple as you have a hip problem, you fix it, and it's better, okay? For adults, and I would say young adults, and even teenagers in MPS, hip arthroplasty or hip replacement is a viable option. And I don't need to tell this crowd that there's multiple medical comorbidities, and for these patients, because they're small and their bones are abnormally shaped, it's technically complex. And this is just some data from the literature on hip replacements. And I think really what, this is older data with 13-year follow-up, and they just note that it's technically challenging. And if you look at the outcomes, you'll see some of these Kaplan-Meier analyses where how many survived at the end, and here it's probably about 50% survived after 15 years. That's not so bad, because most hips, even in average statured adults, we expect them to only last about 20 years. So you can have a reasonable outcome with hip replacements in patients. And I think the one telling thing here is that their one death was an MPS 6 patient, so for airway issues. And I'll touch a little bit based on that, but I know Dr. Harmatz is going to talk about this as well. And so again, more data just to say that you can do hip replacements. And I think and this is newer data with better outcomes. You can see this better Kaplan-Meier survival analysis with less complications. So we're getting better. Knock knees present early in life. We can use what's called guided growth. Now, surgery for knock knees is probably, bang for your buck, the best surgery you can do. It's a small incision. Now, this patient overcorrected a little bit, but we know that a certain number of these patients will get what's called a rebound, and so they'll go back. So the goal is to slightly overcorrect, take the plates out, and then hopefully end up with straight legs. There's a lot of different ways you can fix knock knees, though. You can cut the bones, do osteotomies. This is a patient who had hip surgery, knee surgery, multiple times, and in the end, ended up with nice straight legs and hips that were located. And again, this is from literature from DuPont. Guided growth, and I apologize because you can't see the top of my slides, but it works. You get nice correction in MPS. So some people will say, well, guided growth doesn't work in skeletal dysplasias or MPS. It does. All right, it works quite well. You just have to sometimes be a little more patient with it. And then I'll end up with the hands. Carpal tunnel syndrome is very common. Every child up to age 5 should probably have routine testing for carpal tunnel syndrome, at least until they're old enough or cognitively able enough to tell us whether they're having symptoms or not. Because most of the time the kids won't recognize the symptoms. In MPS 1, we have what's called trigger digits, and those can be often released at the same time. And you can see here, it's a little hard to see, but this is the median nerve. This is the nerve that gets compressed in carpal tunnel syndrome, and you can see it's extremely compressed by this accumulation of materials here. So, and I often get yelled at by families who say, my kids have pain, but most of them are asymptomatic. Some might be symptomatic. most kids don't recognize the symptoms. So that's why it's important to test them. And so this is just that median nerve and it being compressed. And you can, the symptoms are sort of sensory related for the most part. The median nerve is largely a sensory nerve. And so you'll see the kids doing, weird things with their hands, gnawing, decreased sweat, and so forth. So, and then here's just a surgical view of the tendon release and decompression at the same time. So I'm not going to get into this too much because Dr. Orchard is going to talk about this, but I do believe that stem cell transplant probably reduces some of the burden. We know the kids, at least most of the kids I've seen who've had transplants end up taller than kids who don't have transplants. So there's something getting into the bones. It's affecting them, but they still do have a significant residual burden of bone disease. But you take a kid, and this is Dr. Munzer's photo, but you take a kid like this and you can turn them into one like you see on the right here where they're climbing and playing. And so again, I've already shown this. Hip dysplasia tends to get worse despite having bone marrow transplant. There is a certain incidence of spinal cord compression, but you have less of it if you have an early transplant and you have higher enzyme levels. And then carpal tunnel syndrome is less in early and more enzyme. So enzyme replacement therapy improves endurance. It doesn't really get into the bones. It probably does reduce joint stiffness, however, and certainly decreases fatigue. But there's a lot of other issues that it fixes, like cardiopulmonary issues. So I don't want to take credit for that. And then there's a lot of talk about early initiation of ERT, and we have these sibling studies which show that younger siblings who were started at a younger age because they had an older sibling who was identified and so they had an early diagnosis, potentially have less disease of bone disease. And here's a long-term follow-up from Japanese pair of siblings. And if I look at this X-ray on the right of the less affected sibling, I still see bone disease there. It's just not as bad. So, and then as far as there's some work going on with gene therapy now, and so Lachlan Smith has been doing this in Philadelphia, and so when he did the gene therapy on these mice, they found that they survived, but they still had really bad bone disease. So even with gene therapy, we have a ways to go. And then again, I didn't realize that there was going to be a talk on this, so I'm not going to steal Dr. Harmatz's thunder here. But when you talk to your surgeon, it's not just the surgery; it's the anesthesia if you're going to have surgery. Okay. And I'll just kind of leave it at that you need to have a preoperative evaluation, and there needs to be neuromonitoring for all cases exceeding 1 hour in length. Okay, and so again I'll skip this, but this is my take home, and this was an issue that Dr. Walker and Dr. McKenzie and I have really been trying to bang the drum on over the last 10 years. Because we know of at least 20 kids with MPS who have gone to sleep for a lower extremity surgery, a leg surgery, but woke up with a spinal cord injury. And then they're permanently paralyzed. And so you can do, this is mine. This is why I became aware of this. I did what I thought was this fantastic hip surgery. And then, the next morning I go to see the kid and he can't move his legs. And so, he had this very subtle deformity, and this MRI I got because I was lumping my anesthesia. I got an MRI under anesthesia, and then I did the hip surgery, and I knew he had this sort of deformity, but he's got lots of room there for his spinal cord. But then you can see this blushing here in the circle. So, and I've had these, Dr. Walker's had these, Dr. McKenzie's had all, but we know better now, so we monitor our patients. So that's something you need to be aware of. And so there is some information. This is a group that I belong to for families and physicians on perioperative care and other things about skeletal dysplasia. So I would encourage you to go to this website if you have interest in learning more about this, and if you want handouts to take to your doctors. So in the end, again, does orthopedic surgery improve quality of life? Well, we hope so, but we're not really sure because the data is just not great. So I'll just leave it with this. I won't summarize again, but just be prepared, be thoughtful, and hopefully by coming to these meetings, you'll have the information you need to be armed to proceed. So thank you. And this is from our run a couple years ago, a couple different runs. And I'm just going to announce, if you haven't heard, I'm moving to Denver in October, and I will have a new contact. So, but Leslie knows how to reach me. She can find me anywhere in the world, anytime. So, I appreciate your time.
Thank you, Klane, for a wonderful talk. And just to add my 2 cents of emphasis on the neuromonitoring, we cannot talk about that enough. So please, everyone, make a note of that. Our next talk is on anesthesia and airway complications. And Dr. Paul Harmatz is going to do that. He's a professor in residence, the Department of Pediatrics at the University of California, San Francisco, in UCSF Benioff Children's Hospital in Oakland, where he is also the medical director of the Pediatric Clinical Research Program in MPS and related disorders. He also serves on the Society Scientific Advisory Board. And during the past 20 years, Dr. Harmatz has been busy. He's participated in clinical trials developing therapies for MPS 1, 2, 3A, 3B, 4A, 6, and 7. And has managed clinical care for patients with MPS living in Northern California, as well as patients that are willing to travel to Oakland for their care, which is what my family does. He means a great deal to my family. And really, he is one of the most versatile doctors that I've ever run across, because being a gastroenterologist, he has transformed that into being an expert in management of MPS patients. And now he's going to speak to us on anesthesiology, so I think you'll see he's very versatile. Welcome.
Thank you, Steve. That was a very kind introduction. I am really stretching with this talk, and Klane had some discounting of his expertise outside of orthopedics. Well, this is really a long shot, but I hope I can give you some of the high points, and Klane did a great job overviewing the importance. You know, we talk a lot about building multidisciplinary teams, and how you really want to find a pulmonologist and a cardiologist and a psychologist and an MPS expert, GI, all of those. But if nobody really thinks how important anesthesia is, and my belief is that the first most important person on your team is your anesthesiologist. And you go to most hospitals and you pick your orthopedic surgeon, you pick our neurosurgeon. They have great outcomes. They've done 20 procedures, but you don't pick your anesthesiologist, and you just get assigned whoever's in rotation, and you hope for the best. And we have 20 anesthesiologists, so if we spread all our cases, each one of them would have had 5-10 case experience over 10 years. So it really is important for whoever's managing your MPS team. And again, a big plug for centralized care, which we don't get enough of. You should be looking at North Carolina or looking at Seattle, or picking a program that really focuses on MPS. And we did, I think about what it took to find what characteristics of an anesthesiologist you really want to use to pull a person into your team. And it probably takes, number one, you're the best anesthesiologist in your program. We had 25 in Oakland, but there was probably only one that had the sort of basic willingness to take a challenging case, a case that's really going to be difficult and complicated, and it needs to be the calmest person in your anesthesia group, the person that doesn't get flustered, that doesn't, that is really able to make judgment calls about, do I go ahead with surgery? Do I back off? Do I try again the next day? So not someone who tries to force the process because they have a surgeon standing waiting to do their neck decompression, which is really important, but it can be done the next day if the stars aren't aligned in that one procedure. You want to look for the person who's the best fiber optic anesthesiologist. So, and that, it's a challenge because it's probably used much more in the adult realm than in pediatrics, and you can have great anesthesiologists doing standard laryngoscope intubations and very experienced, but if they're not really comfortable with fiber optic, and it's a fine skill. It's like starting IVs. It's doing lumbar punctures. It's the person who has the best hands and is most comfortable doing procedures, not just running a machine with gases and monitoring outcomes or monitoring when to give another drug. It's really the person who loves to do procedures. And the second probably criteria that helped us with the type of anesthesiologist we ended up with, and I didn't pick it on this basis, but our MPS anesthesiologist is also the cardiac surgery anesthesiologist. So he's most used to maintaining blood pressure and keeping perfusion stable, and he's used to doing it in open heart surgeries and valve replacements and going on and off pumps. And so that is a skill that you can ask your MPS coordinator or the director of the program to try to find a person like that. And if I gave you one bottom line, I'll probably use up a third of my talk, but Liz Bronlund has reported cases. We know that the coronary arteries are narrow. Probably every artery in the body is narrow and is limiting perfusion. And we tried early on patients to do cardiac function studies, perfusion studies before procedure, and it's a difficult type of thing to do in an MRI with pharmacology and speeding up the heart and looking for perfusion effects. And Richard Rowe is our anesthesiologist. He said, if you can't do it and the surgery is vital, I basically will just treat this patient like an 80-year-old with severe coronary artery disease. And so every principle that they use for that type of surgery applies. Richard was an adult anesthesiologist before he became a pediatric person. Maybe that helped a little bit, but those are some of the basic. I've probably given you the basics for the whole talk, but this is a talk that Richard put together. I wish he were here. He wanted to come. He's on vacation. His wife said it would be probably grounds for divorce if he came to the MPS meeting, but hopefully you'll have a chance to meet. And I know Steve has great respect and trusts Richard beyond measure, but our neurosurgeon is quite proud that he's probably done 30 decompressions without a complication and thinks that it's his neurosurgery that's done it, but I sort of bite my tongue and know that it's probably Richard Rowe and the anesthesiologist that's been the most critical factor. So Richard said a really young MPS patient is sort of like an infant. The risk is not so great in that age group as it is as the patients grow and their airways get smaller and their deformities and perfusion gets worse. And so it's a changing risk level over time. He reminds us that every MPS patient won't have the same risk, and until he's actually done a case, because everybody falls on a bell-shaped curve. You have normal non-MPS patients who are difficult and some that are not so difficult, and the same is true with MPS. So he can pretty quickly pick out the kids that he's only willing to do at the main hospital, even though we only have a 1.5 T magnet. We'd rather go out to the surgery center, which is off-site with a 3T magnet. And he says, a 6 or 7 year old, 10-year-old MPS 2 patient, I'm not comfortable going until I've done this case once and seen what the airway looks like and what problems I'll have. So you all know the answer to this question. Is anesthesia risky for MPS patients? Yes, it's really high risk, and it's probably the most challenging time for any of you in your sort of taking care of your kids, is making a decision about going into surgery. And you look at the literature, when I was reviewing case reports, trying to decide on patients maybe coming into the original MPS 6 trials, and you'd read about these really difficult attempts at cervical decompression, and basically most people were avoiding it because the outcomes had been so challenging, and patients had been left with injury that Klane was describing with paralysis. And it happens now, but it should be an incredibly small risk. But go in, with Richard as the expert in our center, and now he's trained, he finally is facing retirement at some point. He's handpicked the person he thinks would be the best to take over. He's mentoring him. He's done a lot of cases with him. He's also probably the second best fiber optic person. But the good news is, as Richard said, is over time, when he's had the same patients over 20 years, and he's been able to see how they've changed in most of our patients, it's changed with ERT, less so with transplant, because much smaller MPS 1 group. He thinks clearly he's having less trouble and less challenges with anesthesia. So that's good news. And some people, even with ERT, don't have the same type of improvements, and we recognize the problems that Klane was mentioning with the trachea, the growth of the cartilage in the trachea. It may be a developmental problem or an injury that has occurred before the ERT has started, rather than after ERT, or cardiac issues where the ERT is not having as good of effect, and over time the valves have become worse, and the coronary arteries we still worry about even with ERT in place. Neuroanatomy and the arterial perfusion we mentioned as a concern. We said that MPS patients are not at all don't have the same levels of risk as each other. He does categorize, and you've heard much of this from Klane already, that with each of the different types of MPS, you can classify some that have high, some have low risk. We've had more experience with Sanfilippo in the last 5 years, and he feels they have very low risk on all of those difficult categories that I mentioned: cardiac, airway, neuroperfusion, and C-spine. MPS 4 have low cardiac, but everything else high, and particularly spine, high risk with compression and instability present, and MPS 1, 2, and 6 all with high risk across the board. So just moving down the systems, it's difficult from mouth down to into the airway. There are problems, and with the mouth and tongue blocking, most standard intubations. That's your first challenge. Limited mouth opening challenge. You'll see why fiber optic nasal intubation will move around those problems. Hypopharynx is a major problem with the gag storage. Large tonsils will obstruct your view, and both of those will contribute to obstructive sleep apnea, which is really a problem when the tracheal tube is removed and you're left with an airway that wasn't performing well before and now is really obstructive. C-spine we'll come back to, but definitely have to avoid hyperextension, and intubation becomes difficult without hyperextension. That's the classic step. Klane didn't mention, but he literally after his events built a sort of warning flag that goes into their medical system and the electronic record, and it flags every patient that has a high-risk spine and warns anesthesiologists. We can ask Klane how he's assigned an anesthesiologist. The one time I was getting pressure from the head of anesthesia to use somebody other than Richard. Richard would not always be available. He might be on vacation, and someone else needs to do a case. So we assigned a teenage MPS II patient, and a person that was anxious to do it, started the case, and then was not able to intubate. And fortunately, Richard was present in the OR with another case and just came over and helped. But I think since that time, I've never been asked by anesthesia to find another person to assign. And we've been lucky. Richard and his department's been very supportive. He literally will pull out of whatever he's been assigned to that day. Someone else will pick up that day of endoscopies or LPs for hem-onc, and Richard will move over to take care of the MPS patients. So, the lungs themselves also are compromised. You can have obstructive lung disease, all of which affect anesthesia. You can have pulmonary hypertension, a very narrow trachea to deal with. And we mentioned that the heart intrinsically can have leaky valves, which can affect your perfusion. And this narrow coronary arteries worried us for a long time until Richard finally convinced me that he was comfortable treating the patient just like I said, an 80-year-old with severe coronary artery disease. We had a video just showing the classic intubation. This is the sort of view that a standard laryngoscope anesthesiologist, hyperextended neck, sees, and then you can see right in the center the airway that they're shooting for. Most of Richard's MPS patients do not show this. He will go through the nose, he'll go down to that area, he'll see nothing, he'll wait, he'll move around, he'll wait, and then suddenly there'll be a little opening and he'll move into it. So patients sort of comfort with anatomy and where they're working, and really is critical for these anesthesiologists. Some programs talk about pre-op evaluations. Do you have pulmonary? Do a bronchoscopy, flexible bronch a month before, just to help the anesthesiologist. Richard's so comfortable with fiber optic, he doesn't need it, but it is another way if you're rotating people and you need to have a sort of pre-op evaluation and maybe have pulmonary who do more flexible bronchoscopies be present to help the anesthesiologist. Those are the sort of ways around having one person. Anesthesiologists have a grading system, 1 to 4, and it's shown on this slide. The 1 is your sort of slam dunk. Everybody's happy with a 1. You use a laryngoscope, you lift up the tongue, you see the vocal cords and the airway and the glottis area, and this is almost never present with a patient with MPS. By and large, most of Richard's MPS patients are probably grade 4, some grade 3, but all are a challenge. And so you really need a person who relishes becoming an expert at this disease picture. So a normal view on this slide on the left, you're seeing the epiglottis and the airway. It's very easy to know where to push the endotracheal tube. You look at an MPS larynx and you can see that there's no well-defined, you just see a slit there. It's not well-defined. You can easily push an endotracheal tube into the esophagus, which is right behind the epiglottis that you're looking at here. The other, keep in mind, and the red curves are hypothetical, but these curves for the adult and the larger child sort of explain that you have a certain amount of safety time before you're in trouble with during intubation with oxygen desaturation. So you probably, with an adult, you'll have 5 minutes to work with. A 20-kilo child, the metabolic consumption of oxygen is faster. 10-kilo child, hypothetically, is even faster. And Richard's senses, MPS, moves even faster. So you have to convince an anesthesiologist, do not stop breathing. Patient, not only do they need to be handled differently, but they can't be paralyzed. They can't get a drug that stops their breathing, making it easier in a standard adult intubation to put a tube in. So sort of basic principle, treat them like an 80-year-old with arteriosclerotic heart disease. Number 2, never stop normal ventilation. You can sedate, it has to be light. If it's an awake adult, we have adults that we are literally awake, and Richard's talking to them, and he's using his fiber optic scope to intubate while they're completely conscious but calmed and with their nasal passage anesthetized. But you never want to paralyze and lose control of ventilation. So the sort of things to think about with an adult with a difficult airway, as I just mentioned, with an adult, they can be cooperative. You can use some light sedation. You don't have to put the adult to sleep. You put local, it's often cocaine in the nasal passage to move your fiber optic in place. You've prepped them by talking and describing exactly what's going to happen and supporting them while they're doing the procedure. But those are probably the easier end of the spectrum. If you try to do this with a child, they'll be running out of the operating room. They will not hold still. They will not allow you to do anything that we just mentioned. So Richard believes that putting the IV in is probably the hardest part of a child, and he tries to avoid this by using mask, often with a combination of nitrous oxide, laughing gas, and sevoflurane, and avoiding shots. It takes a few breaths. It's very safe. This is a good way to start the procedure, and it doesn't put them to sleep. And he can ask the patient, he flavors he probably puts the scent into the mask, but he can flavor the type of anesthesia so they have a choice. And the mask is not tight, they're just breathing through it, sort of lying in the area of their nose and mouth. And he's monitoring during that entire time. He makes a decision. The SIVO can relax the airway, and so if there is a really strong history of snoring or evidence of an abnormal sleep study, he may bypass the sevoflurane. And but he knows that once they are sedated, and if he does use it and he gets snoring, normally you'll use an oral airway to help keep the tongue out of the way. That's a lot of the snoring. Or you may use an LMA, which is a tube that covers the trachea but doesn't have to go actually into the trachea. So keep in mind, the other thing to talk to an anesthesiologist is make sure they're comfortable with an LMA. And most of the cases that Richard does can be done with an LMA, not with intubation. So basic principle again, don't get yourself or your anesthesiologist into can't intubate, can't ventilate. If that's really setting up an emergency and an emergency trach to try to reestablish ventilation. So an alternate to the sevoflurane, when he knows there's a strong history of obstruction or sleep apnea, is he actually will use an IV to start. He'll give small doses of ketamine, and there's less collapse. It makes safer intubation in that type of patient. So again, I mentioned you use the sleep study, the history of snoring, exam of the airway just in clinic, or with his fiber optic scope from a previous exam, or a pulmonary fiber optic exam might tell him this information. MRI, CT of the airway could also show him an obstruction and convince him to go the way of IV ketamine. So no snoring, mask induction, difficult airway, IV induction. We've gone over, but he re-emphasizes that he will probably not see much at all. Most of the patients will be grade 4, no epiglottis viewable. You're wasting your time trying to use traditional equipment. And this type of glide is just like a laryngoscope. Some people use it. It's more usable with Morchio, but it's for all the other types, it's really not going to be more effective than a laryngoscope. So you have to move to a fiber optic. This is a very flexible, long, small tube. Often the endotracheal tube will be slipped over this tube. This tube goes into the trachea. Your endotracheal tube will go in, and you'll remove this, and you're in place. Is pre-med safe? Yes, but with nursing and anesthesia monitoring. So he will use midazolam 15 minutes before the procedure. It sometimes can make the mask induction a lot smoother, less anxiety for the child. So once they're anxious and they're crying and they're struggling, then you get problems with laryngospasm, and then you're in trouble. So he wants a calm patient, and as midazolam often can do that. So mask, midazolam mask, and then an IV can be started. He'll often use nitrous with the mask. He'll use a small catheter then. He'll use glycopyrrolate to dry up secretions, and then use ketamine for his anesthesia. Klane already mentioned some of the risks with cardiac and neurosurgery, neurologic risks, but we talked about the valves are a problem. When they're stiffer, the flow can be reduced. When they're regurgitating, you don't get the same type of perfusion pressure. So he will not often but always request an echo before a procedure, or if it hasn't been done in a long time or it's a large procedure, he wants an update. That's probably the most important consult for Richard, that and some assessment of neck stability with a flexion extension type x-ray. This is a picture Liz Brownland would show, and it just gives you an impression of what happens in the coronary arteries that feed the heart. And you can see the red is sort of the normal size of an artery. All of the additional material is gag deposition, and you can see how much it's narrowed the artery. And it tends to be diffuse. It's hard to see on cardiac angiography, so it's really a difficult problem to try to predict who has it, who doesn't have it. So maintain vital signs normal. Normally, and this is especially in pediatrics, the blood pressure is allowed to drop because your perfusion is good and the vessels dilate and the anesthesiologist doesn't worry about it. With MPS, you can't do that. You have to keep the blood pressure in the normal range. So he'll have dopamine or another drug that causes the vessels to maintain. Need neuro issues or the cervical spine. You really worry about extension of the neck. This is what a normal neck would look like, with the white is the spinal fluid on both sides of the spinal cord. This is an MPS neck, like Klane was saying. There is a very narrow spinal cord. It's being pressed on both sides, and particularly if there's instability, it can be compressed plus unstable, so your cord is at high risk. But a lot of times these injuries that Klane was mentioning they're not in the area of the neck, and there's an area lower on the spine, maybe where there's a kyphosis with pressure, but also there's a zone where you have poor perfusion lower in the spine, and so you can't really just worry about the neck. Neuromonitoring is the most important advance probably in the last 10, 15 years. It was used on every case by neurosurgeons, but it took a long time to convince people. Now orthopedics very readily will do it. They have long procedures. We usually have gone back to a half an hour. Anything that involves manipulating the head, like oral surgery, or which can be a long procedure, or even tonsillectomy, we'll try to hook up neurophys monitoring. We don't do it, for instance, with ear tubes. Those tend to be very rapid, but it's still the anesthesiologist has to maintain the neck in neutral position. So we don't do it in MRI, which makes me nervous. Those can be an hour-long procedure. Anesthesia has to be very careful with positioning. It can be done, but it takes very special adaptation of the MRI suite. You have to have titanium leads. All the monitoring equipment has to be outside of the MRI machine suite, so it makes it difficult. So beginning and end of the case are always the most dangerous parts. And post-op issues, you'll remove the tube, the trachea is narrow, it closes down. So often Richard will, if it's been a long, difficult case, he'll remove the tube the following day. He always looks with his fibroscope before he removes it to see if there's space around the airway. They use medicines to try to keep to reduce edema, to make it more likely you'll get successful extubations. Final two slides. The top centers are not always the top academic centers or largest hospitals. And Richard's view, there's a world of difference between caring for children with other diseases and those with MPS. protocols are built for other diseases that don't apply to MPS. We've gone over all of those major issues. Hospital doing a lot of MPS research, especially in the last 5 years. Every study is involved in trying to improve neurologic and neurocognitive function. They all are looking at biomarkers in spinal fluid. Every child's undergoing ABR 90 minutes, LP 30 minutes, MRI 1 hour. So they're 3 to 4 hour procedures and need to have neuromonitoring. And you'll have anesthesiologists that have a lot of experience. So thank you. It's been a pleasure. I've loved working with Richard.
Thank you, Dr. Harmatz, for that wonderful talk. One thing I failed to mention earlier is we are going to have a Q&A session after this last talk of the 4 gentlemen that have already spoken, so please be preparing your questions for that. It is, we're going to turn to the blood stem cell transplantation and gene therapy for Hurler syndrome. It's my pleasure to announce that Dr. Paul Orchard is the director of the Inherited Metabolic and Storage Disease Transplantation Program at the University of Minnesota, which we all know is a leading center for the treatment of MPS by bone marrow and stem cell transplantation. He has extensive experience in the design and implementation of clinical trials for the MPSs, and Dr. Orchard has actively worked to build a team of professionals in the various disciplines to provide optimal care for his MPS patients and to offer new therapies such as gene therapy. So we've appreciated Minnesota for many years, and we welcome Dr. Orchard.
Is that working? Yep. Okay, great. Thanks, Steve. Yeah, I got to put this down a little bit, but I very much appreciate the opportunity to be here. It's great to be able to see the families and interact with them. I think those of us that are working with the families, it's great perspective to have to be able to have lunch with them and that's okay, and talk about the issues. So. And I note that we're close to being on time despite Dr. Harmatz and Dr. Munzer's presentation. So I'll try to get going here and stay on time because I think the question and answer period is going to be key if I can figure out how to operate this. Which buttons am I pushing here? Yeah, that's not doing anything. Touch the screen one time? Oh, there we go. Great. Okay, so you saw a slide that's similar to this earlier, and I don't want to belabor it too much, but clearly these diseases are in a continuum. So Hurler syndrome is the terminology we use, of course, for the kids that are severely affected. We used to talk about Hurler-Shea and Shea. Now we're primarily use the term attenuated disease. The paper that I pulled from here, in North America, it's about 70% of the kids have Hurler. But this ends up being an important designation because it affects actually how we propose to treat the patients. So we'll expand on that here in a bit. And I just wanted to make the point, so this is a slide in regards to age of presentation and age of onset of symptoms, just again to show that the Hurler kids generally are quite affected early in life as opposed to the kids with more attenuated disease. And this is also, I think, straightforward to all the families and providers as well, as these are multi-organ system diseases. And it ends up being important both from those of us that are taking care of the patients to identify that kids have all these related issues, and it also ends up being important in looking at the effectiveness of therapy, because particular therapies may work for one aspect of the disease better than others. So what do we think about when we're designing or implementing therapies for MPS I? So Liz Neufeld is going to be honored as is very appropriate here, I think, a little later. But this is from her laboratory back in 1968. So, and I think Paul Harmatz or somebody talked about this a little bit yesterday, but if you take cells from a kid with Hurler, or take cells from a kid with Hunter, or any of these MPS disorders, and you have them in essentially at a Petri plate, and you look at them, they accumulate storage material. And it was noted by Liz's group that if you put normal cells in with these cells from the kids with Hurler or Hunter, that accumulation of the storage material essentially goes away. And actually, if you mix Hunter cells and Hurler cells together, the same thing happens. So this is a concept of cross-correction that we refer to, which is essentially why transplant was proposed as a potential therapy. And actually is important for enzyme therapy as well. So the two standard therapies, we want to think of it that way for MPS I, are really enzyme replacement therapy and transplant, at least at this point. So leronidase was approved in 2003. Transplantation actually started significantly earlier. So the first patient that was done was in the UK by Hobbs's group, I think in 1978, I think is actually when that first patient was transplanted. So had some experience with transplantation before enzyme therapy was available. And as all the families that are on these enzyme therapies know, you have to give the enzyme replacement essentially weekly and for the life of the patient, and it's an expensive intervention as well. Transplant, we have to find a donor to be able to do the transplant, so allogeneic transplant cells requires you to find a well-matched donor to minimize the risks associated with transplant. We have to essentially remove the immune system and the blood-producing cells of the to allow requires chemotherapy, and there's toxicity associated with that clearly, and we'll discuss that a little bit later. But this is considered more definitive therapy, meaning that if you get through transplant and transplant seems to be working, if you have donor-derived cells, for instance, you're done with your intervention. And one of the pieces that's really important in determining what type of therapy to offer relates to this issue of developmental delay. So, I mean, globally speaking, we think of the Hurler kids as having issues in terms of their developmental and cognitive, or having cognitive impairment, for instance, and the patients with attenuated disease as not having that issue. It's not quite that clean and clear, but that's the bigger picture, how we envision these things in terms of therapy. And just to show what the cognitive decline has looked like for the Hurler kids. So very early in life, the first few months, kids, generally speaking, are quite intact in terms of their cognition, but over time they continuously lose ground. So this is one of the things that is dramatically important in considering treatment, especially for the Hurler population. So enzyme therapy, so these enzyme molecules are quite large, and they don't penetrate into the brain very well. So there's this blood-brain barrier that has evolved to help keep toxic things out of the brain, but unfortunately in this sort of circumstance it keeps the treatment essentially from getting to the brain. So that's a limitation in enzyme therapy if you're going to have somebody who's got cognitive impairment and you want to get enzyme into the central nervous system. So the concept with transplant essentially is if you can establish donor-derived cells, so these are normal cells making enzyme, and they can circulate through the body and provide enzyme to the cells that are deficient, that this is a means of slowly, continuously providing enzyme for the life of the patient. So the idea is, again, in terms of this cross-correction, if you have cells going through the bloodstream that are providing a source of enzyme, that the tissues can pick it up and utilize that, and that can help alleviate the storage of glycosaminoglycans. Importantly, though, if you have cells in the brain, the central nervous system, some of these donor-derived cells can make their way into the brain. And these tend to be, we think, microglia-like cells, monocytes, but exactly, what proportion of the cells are of what derivation is a bit unclear. But if you can get these cells into the brain, they can also produce enzyme, and they can then deliver enzyme to the cells in the central nervous system. So this is primarily why we still use transplant now, because we have an opportunity to better treat the brain than we have with just enzyme. Now, someone might ask, so if this seems to work for MPS I, does it work for MPS II or does it work for MPS III? And the answer essentially is no. So transplant seems to work better for MPS I than it does for MPS II, than it does for MPS III. And why that is, I don't know. I would love to know. We speculate that maybe for MPS II, you just need to deliver more enzyme than you can get away with for MPS I. And MPS III might just need more enzyme than MPS II does. But we don't have a great way of sorting that out. I mean, presumptively, if you do the transplant in the same way, the same proportion of cells are going to make their way into the central nervous system for all the diseases. But it may be that you just need a small amount of enzyme delivered to help stave off the neurocognitive decline that happens in MPS I, and you just need more for the other diseases. So based on this, so this is from a review article, but if you look at the left side of this, so the recommendations are for the kids that have MPS I that are young, less than 2.5 years of age, which is primarily going to be kids that are diagnosed with Hurler. Those kids go on enzyme and then ultimately would get transplanted. And if you look on the right side, the kids that are older, and so these are either kids that have attenuated disease or maybe Hurler kids that were picked up late and maybe are less likely to benefit from transplant, but those patients may just go on enzyme and stay on enzyme. So there's a big fork in the road here as to what therapy you might offer a patient with MPS I, essentially based on, again, whether they're Hurler patients, they're anticipated to have the neurocognitive defects versus those that aren't. So this is from Julie Eisengart's paper here, but untreated patients with Hurler, unfortunately, most of those patients die by the time they're 10. And there were a number of patients that, after enzyme became available, decided that they didn't want to go through the risks of transplantation and wanted to be just treated with enzyme. And so that's kind of the middle curve here. And as is apparent, those patients don't do as well as those patients that were transplanted. But I think it's also important to recognize that the curves with transplant are not flat. And as we look at some of these patients that are now 20 years out, maybe close to 30 years out, some of these patients, despite having gone through transplant, are still dying of their disease. What exactly they're dying of is still a bit unclear, but we think it's airway issues, cardiopulmonary related problems, but their life expectancy isn't normal having gone through transplant, which is something we need to better understand and recognize and be able to hopefully improve on. So in terms of outcomes, if we're talking about therapies, again, there's another slide that kind of looks at things in a little bit different direction, but if you look at enzyme replacement versus transplant and what do they fix or partially fix, that's the thrust of this. So for instance, the soft tissues such as the liver and spleen, enzyme therapy and transplant both work quite well for. The cognitive piece, as we talked about, enzyme therapy doesn't help very much. And neither of these interventions totally fixes the skeleton. So this is the Kaplan-Meier curve, which is essentially a survival curve. So as transplanters, we reduce a lot of things to Kaplan-Meier curves. But the idea here is that so this is from a paper that pulled data from a number of different centers that do transplant for Hurler, and tried to look at various aspects of the disease and how things were going for these patients. And so the lower curve here, the patients that were transplanted in the 90s, survival was about 50%, but as we improved on the transplant side and had more availability of better donors and whatnot, outcomes have improved. So the key thing of this is that there's significant risks associated with transplant. There's no two ways about it, but we have been able to improve survival of the kids going through transplant for Hurler. Now, within that is the same data set, but in that group, the median age of transplant was 16.7 months. So this essentially looks at that in that context. So the kids that were older versus the kids that were younger, using that dividing line, we looked at survival, and the key thing here is that the kids that are transplanted earlier have better survival than the kids that are transplanted later. In terms of the cognitive outcomes too, so at least in this analysis, 56.9% of the kids were normal as defined by an IQ of 85 or better at the time of transplant. 16.5% of them were severely affected with very low IQs. But the point I want to make here is that even after transplant, even the kids that have gone through transplant, survived transplant, there is some loss of cognitive ability before they stabilize. So this is a limitation of transplant as well, and Julie and others can kind of expand on this. The boys generally didn't do as well as the girls. If you come in with a low IQ, that's a predisposing factor for a poor outcome. The kids that are older, as you might expect, don't do as well. And then the TBI refers to total body radiation, which is one of the things we used to use to prepare kids for transplant. We don't do that anymore, but in this analysis, TBI, or radiation, didn't help your cognition either. So this is a slide in terms of growth. And again, this refers back to the skeletal changes that are associated with MPS I. And so there's dotted lines here. The left side is boys, right side is girls, but the dotted lines are the normal growth curve. And then you can see that the darker lines actually are the growth curves for the Hurler kids that have been transplanted. So as you can see, over time, these kids tend to fall off the growth curve despite having gone through transplant and despite having enzyme related from the donor cells. So we're not curing their growth despite having gotten someone through transplant. And so Klane was waxing eloquently about this obviously before, but there's a number of different orthopedic procedures that tend to happen after transplant, and this was the observation in that same group of patients, is that getting through transplant doesn't mean you aren't going to have skeletal related problems. So a number of these kids have knee and hip surgeries, back surgeries, carpal tunnel, cord compression. But if you look at these a little more closely, so this is kind of focusing on carpal tunnel now, they broke the groups apart into the kids that tended to have more enzyme after transplant and kids that had less enzyme after transplant. And if you have more enzyme, it's less likely that you'll need to have carpal tunnel surgery. So enzyme levels end up being important. And they also looked at it in terms of age. So the kids that are older are at higher risk for having to have carpal tunnel surgery. And this same sort of observation was present for a lot of the procedures that were in the prior slides. So one of the things that I kind of keep coming back to and points I really want to make is age is important, enzyme is important in terms of outcomes. So just to kind of wrap up what we were talking about in terms of transplant for MPS I, it's primarily the Hurler kids that we transplant, not the attenuated population. Survival has gotten better, and in the large centers tend to publish their outcomes, and it's 85 to 90% survival now. And not to kind of besmirch my other transplant colleagues, but I'm afraid the large centers that have a lot of experience publishing very good outcomes can be a little bit misleading. Because the transplanters tend to say, well, we have the same chemotherapy that these large centers do. We have the same access to donors that these other centers do. So, you know, why shuttle them to the centers that are the larger centers have more experience? But I think it's misleading because treating a Hurler kid that's 1 is not the same thing as treating a leukemic who's 1. I mean, there's airway issues, there's cardiac issues. These kids get in trouble in different ways than the leukemics do. So I think we need to kind of separate out which centers, you know, have sufficient experience to be treating the patients with transplant. So my 2 cents on that. So what can we do to make things better? So as I was alluding to, age seems to matter. Can we identify the patients earlier, intervene earlier, because that may have great advantage. I pulled this off the website last night, so, and if I counted this correctly, there's 34 states that are now screening for MPS I, which is actually a little bit more than I thought. I thought it was kind of more 28, 29, but this is important, and as people might understand, it's kind of evolving and new states are being added all the time, but being able to pick up these kids at birth, essentially, and intervene early is going to make a huge difference. So this is a major step forward, I think, in the treatment of kids with MPS I and other diseases as well. So in terms of the enzyme and being able to deliver more enzyme, so, I mean, we've refined transplant a lot over the last 20, 30 years. We are more precise in terms of our chemotherapy. We can find better donors. We have better supportive care. So we can get kids through transplant better than we could 20 or 30 years ago. But if somebody 30 years ago went through transplant and they're fully engrafted, meaning all the cells in the blood are donor, they aren't necessarily doing any better than the patients that we're transplanting now in terms of efficacy of treatment. So if we can deliver more enzyme, that would be advantageous as well. So this is just from a paper that was looking at gene therapy as an approach in the mice. And so this is a lentiviral-based approach. So lentiviruses are essentially based on the AIDS virus, and they remove all the pieces that are related to the normal AIDS virus and replace it with the ability to deliver enzyme, for instance. But this is looking at the outcomes in the mice. And just a couple points I wanted to make in regards to this. So in these 2 figures, the black dots are the untreated Hurler mice, or IDUA deficient mice. The normal mice are the blue dots. And then if you look at the mice that are transplanted, those are the green dots. But the mice that were treated with gene therapy are the orange dots. And so on the left side is how much enzyme is present in the blood. And as you can see, you can deliver a lot more enzyme with gene therapy than you can with transplant. So this is on that axis, that y-axis, that's actually a log scale. So it's a large amount of enzyme we're talking about. And then on the right side, similar, they're actually looking at the blood cells in the mice that have been transplanted. And there's both 4 weeks and 6 months in terms of those orange dots there. And 6 months is a pretty long time for a mouse. So the idea is that this is a stable type of therapy. So one of the other directions to look at it is what's the size of the lysosomes in these mice. And so Joe had shown before that, you know, what the accumulation of storage material that you get in these cells can be huge. So this is addressing it from that standpoint. The black bars are the untreated IDUA deficient mice or Hurler mice. The transplanted ones are green bars, and then the orange are the gene therapy bars. And as you can see, transplant makes a difference in some of these various organs clearly, but gene therapy better corrects the lysosomal size than transplant does. So this is from a presentation from the World Meeting back in February, looking at a pilot of gene therapy for the MPS I kids. So this was done in Milan, and there were 8 kids on this pilot study. There's chemotherapy associated with this as well, fludarabine and busulfan. Rituximab is to help get rid of some of the B cells, but then the kids are reinfused with their own corrected cells as opposed to using somebody else's cells. And this is essentially kind of how this works. So the kids are identified. They have to have kind of a big IV placed. There's a procedure called apheresis where you take blood out and it circulates through a machine that spins out the cells of the right density, the cells that we want, and the blood goes back in. And that's a 4 to 6 hour procedure. The idea is to get the kids' own blood stem cells. Those cells are then sent for manufacturing, and you use the virus that was designed to express the IDOA gene within the cells. The cells are frozen down, and there's a lot of quality